Well, welcome everybody to our very, very special Hope Zoom call this Saturday. We are pleased to have a special guest, Dr. Maggie Senthil, with us. And some of you are new to our Hope Zoom calls, which we do have twice a week. And so I want to make sure I tell this group about PMP Pals, and then we will get right into Dr. Senthil's presentation. So my name's Adele Jason. I am the president of our board and also a patient and survivor. I'd like to share my screen. Okay. Just bear with me. Okay, can everyone see my screen?
Yes.
Okay. Um, just to uh, so PMP Pals, we were founded in 1998 by our founder, Gabriella Graham. We are the world's oldest global patient support group, providing hope and support to patient and caregivers. Just an overview of some of our programs. We have our Hope Zoom meetings, which are group patient and caregiver support calls. We hold those twice a week, Saturdays at 11 a.m. Eastern and Wednesdays at 6 p.m. Eastern. We also have an annual in-person meetup every year in October. Uh, we also have physician presentations and resources. And so today will be one of those presentations. We do one-on-one mentoring. We have various support programs, including sending cards, bears, our Barad blankets, and we have our Caregivers Corner, all to make sure our patient and caregiver community knows that you are not alone and that we have hope for you. And so we do hope you will connect with us. And if you want to get to our website, there's the QR code. So please take a picture. And, we hope you will continue to join our calls and our programs. So with that, I am just thrilled to present our special guest this morning. Dr. Maggie Senthil is a board-certified surgical oncologist at the University of California at Irvine, and she specializes in the management and treatment of advanced abdominal cancers and peritoneal malignancies. She's a surgeon scientist, and I just love the research and all the expertise that she brings. Uh, she earned her degree at Madurai Medical College in India and completed a residency in general surgery in New Jersey and Newark, and did your fellowship in City of Hope. She's the director of the peritoneal malignancy program and co-director of the melanoma program at the UCI School of Medicine, Department of Surgery. Her interests include the design and execution of clinical trials to test treatment approaches for managing advanced cancers. She's also studying novel blood-based liquid biopsy techniques for early cancer detection. Through bench to bedside translational research and technical excellence, Dr. Senthil seeks to improve the diagnosis and treatment of patients with advanced cancers. Her focus is on healing the body as well as the mind and spirit. I'm also thrilled to announce that Dr. Senthil is the recipient of the 2026 Gabriella Graham Patient Advocacy Award. This was presented to her about a month ago at the Advanced Cancer Therapies session sponsored by the Society of Surgical Oncology. And as I mentioned, Gabriella is the founder of our PMP Pals group. We are here because of her, and there couldn't have been a more deserving recipient this year. So we are just thrilled. So with that, I'm going to turn it over to Dr. Senthil.
Thank you so much for that kind introduction, Adele. And it's such a pleasure to be here. Thank you for the invitation and also the opportunity to be able to share some of the work that we are doing with regards to this disease process, I would say, when it comes to improving the outcomes of our patients. So I'm truly, truly honored to be here. And as you mentioned, receiving the Gabriella Graham Award is probably one of the highest honor I have received in my career. And I would continue to know that that would be the case. It's because there's nothing more important to us than being an advocate for our patients. So thank you. Right. With no further ado, I will go ahead and get our presentation started. And I know that this is an interactive session, so there's going to be a lot of questions. However, I will start off by talking about a surgeon's perspective, right? So a surgeon scientist perspective. So there's going to be a lot of research aspects that I would be sharing, but I want to give a big kind of categorization of what I'm going to talk about. I do think that in order to understand the challenges, we have to first understand the types of appendiceal neoplasms, and then the diagnostic challenges first, and then how do we improve it, and an approach to personalized treatment and where we are around it is because I think a lot of patients have questions around that as well. Now, many of you know that there are different kinds of appendix tumors essentially. Right? The big categorization, I've grouped it in a very big category, and there is a lot more nuances to this classification. But when we think about it from a big picture standpoint, non-cancer mucinous neoplasms, which are tumors that arise from the appendix but do not have the cell type to be classified as a cancer. So these are called as a non-cancer mucinous neoplasms, and Lamin is a low-grade appendiceal mucinous neoplasm, and Hamin is a high-grade appendiceal mucinous neoplasm. And so this is a specific subgroup of appendix tumors, which are mucinous neoplasms. Then we have the mucinous adenocarcinomas, which are truly cancers, but they still have that mucinous features. And they could be based on the type of cell type, essentially, it could be well or moderately differentiated. So it all indicates the aggressiveness of these cancers. And then certainly the poorly differentiated with or without signet ring cells is a different category, even in the mucinous adenocarcinoma, as the treatment approach, as well as the likelihood of recurrence and the subsequent outcomes for these patients is certainly different from the other groups. And the non-mucinous adenocarcinoma are cancers that do not have that mucin-like picture in them. And usually goblet cell adenocarcinoma could be a non-mucinous adenocarcinoma. It could also be mucinous, but I put that here is because majority of the goblet cells could be non-mucinous adenocarcinomas. And certainly goblets require a different kind of attention, again, because of the aggressive histology and behavior as well as the outcomes. So keeping this in mind, so appendix tumors could be non-cancer and cancer. That's actually the big thing that I want to drive is because the treatment approach as well as the outcomes are going to be different for these patients. Now, I'm going to just show a few examples of how we see it, right, as physicians, just so that we can get this taken care of. Now, here is a CT scan of a patient who was referred to me. Fortunately, you can see, if you can see my mouse moving, here is a mass-like region right next to the right side of the colon, which is called cecum. On the same patient, you can clearly see the small bowel as well as this very well-defined, discrete mass that looks like it is contained. It doesn't seem like there is any opening of that wall that we see here. And this is a very classic appendiceal mucinous neoplasm type of picture that has not ruptured. And this is what it looked like. I did a surgery for this patient, and you can see how the appendix looks like in a patient like this. There is a stalk, here is the cecum to which it is attached. And when you open this, and this is what it looks like. So we put a ink on it. That's what pathologist does before cutting open any tumor. And when you open this thing, you see this gelatinous mucinous material that is filling that appendix. So this is a very classic contained mucinous neoplasm of an appendix. This ended up being a low grade. Depending upon the type of cell, it could be a low grade or a high grade appendiceal mucinous neoplasm. Now, one of the issues with this is what happens when this tumor finds its way through the appendix wall. And here I'm showing a cartoon of the abdominal cavity. In the abdominal cavity, organs are embedded in this layer called as peritoneum. Anything that lines the abdominal wall is called as parietal peritoneum, and anything that lines this blue lines are all covering the visceral organs, and this is called as visceral peritoneum. But essentially, this is the layer that covers the insides of the abdomen and the abdominal organs. And the cavity that is present is called as peritoneal cavity. So when a tumor, and this is just an example, when a tumor mass starts and is able to penetrate through the wall of that visceral organ, it could be colon, it could be appendix, it could be stomach. It doesn't, but the concept is the same. And this could be just mucus coming out, the mucin just coming out. So when it penetrates through it, and it's now has penetrated through that outer layer, it now has access to the peritoneal cavity. And when this spills over into the peritoneal cavity is when you see this process, peritoneal dissemination. The peritoneal dissemination, depending upon the nature of the cancer or the tumor, could be either a PMP, I mean, we call it PMP. PMP is a non-specific term to talk about cancers that have or tumors that have spread to the abdominal cavity. But essentially, that tumor, whether it is an mucinous neoplasm or an adenocarcinoma, could spread into that abdominal cavity, creating what is called as peritoneal carcinomatosis or peritoneal dissemination, and it could be acellular mucin, essentially. But this is what a CAT scan will look like in those patients. Now, with that said, here is a variation to what I had shown. So this is another patient who presented to me, and these are some scans that were done prior to the patient coming to see me. And here what you're seeing is kind of this like a loculated, but however, and pockets of what looks like either an abscess or a mucin, right? And it depends upon where the patient ends up for their care. In this patient, they thought that it is an abscess from an appendicitis. They put a drain inside that and ended up finding that what came out looked like mucin. And the patient was then referred to me. Here is a section of the CT scan showing here is the colon right here, and there is so much of the mucin kind of covering up that region, heading down into the pelvic region, and there is also a little bit of what looks like a gray mucin around the liver. Now, this is a ruptured appendiceal mucinous neoplasm, and this is what the intraoperative specimen looked like. And you can see here, unlike the prior contained tumor I showed, in this case, you can see the mucin tracking around the colon. There is mucin that has come out of the appendix. So this is the appendix right here. And you can see the mucin has extruded out of the appendix and has now found its way along the lining around the colon. And you can see I have taken more than the average colon because here is the peritoneum along with which the colon was resected. Now, the outcomes of these two patients are going to be different. A patient who has got a contained appendix tumor, even though it's an appendiceal mucinous neoplasm, would be different from a patient who now has an uncontained or a perforated appendiceal mucinous neoplasm that also has peritoneal dissemination, even if it is a mucinous. So this is some of what it looks like. And I'm showing this picture is because some of the questions I get asked is that, can this be done laparoscopically? Would treatment other than chemotherapy, any other treatment would work and so on. So let me see if this plays and just bear with me. So here, this is what it looks like. It's just merely a mucin, right? And here is what that peritoneum looks like, and we are going in and we are exploring that. And much of what we are seeing in a mucinous neoplasm is going to be this jelly-like material that is stuck to the lining, that is hanging out in the crevices of the abdomen. Now, trying to scoop this out laparoscopically may not be possible because you're going to spill it over, and you really need to be able to have a good control of that area to adequately remove it. So that's where the nuance about Can this be done laparoscopically? Should this be done open? All of those questions come about. It is about what we are trying to do in these tumors. Right. And next, I want to switch gears about carcinomatosis. So I've shown you what a mucinous neoplasm and rupture of a mucinous neoplasm looks like. It almost looks like this gelatinous material that has extruded out of the appendix. On the other hand, when patients truly have carcinomatosis, even mucinous, appendiceal adenocarcinoma, carcinomatosis, that might look very different. Now, here is a CT scan picture showing omental caking, right? So this is omentum that has now been infiltrated with mucinous tumor, in this case, a mucinous adenocarcinoma. And this is what it looks like inside a patient. Now, here is this omental caking that you're seeing that is corresponding to the CT scan, where that mucinous tumor has just infiltrated that omentum. Again, this is such a common thing to see in patients with carcinomatosis, and this can happen even with a lamin or a Hamin. It's just that this one happens to be an well-differentiated mucinous adenocarcinoma, a patient for whom I did a cytoreductive surgery. And surprisingly, you can see how clean the small bowel looks, and that's one of the positive things about mucinous cancers, is that the likelihood of small bowel involvement is less frequent compared to a patient who has a poorly differentiated adenocarcinoma. And this is what that omental carcinomatosis looks like. When you lift it up, there are multiple mucinous tumor nodules that is infiltrating that omentum. So, now, why is this matter? Why do we think about this in such a depth? It matters because it changes how we would treat it, and it changes as to how we would even do the resections, right? So here it's a variation of the peritoneal metastasis. And mucinous acellular mucin-like tumor, even less vascularized tumor, is going to sit on the peritoneum and will not get through into the layers of the peritoneum. It is not as invasive. So there are certain cancers, just based on the grade and the mucinous nature and so on, we can ascertain whether this is going to be deeply invading into the peritoneal layer, or is it going to be just touching the surface, and what type of resection would be sufficient to have the entire cancer or tumor removed. And so this is the difference, right? So either it is adhering, like the tumor cells are just adhering to the surface, or is it deeply invading through the layers of the peritoneum? And this is just an example, a cross-section microscopy example of what these cancers can do. So you have two different groups of cancer based on the aggressiveness of these tumors. And this is a cartoon of peritoneum. And what I'm showing here is that this is the lining, the peritoneal lining itself. And here, that's going to be the location of the tumor. The blood vessels are located in a much deeper layer, and there is a barrier that separates the location of tumor from the blood vessels. It is called as blood peritoneal barrier or plasma peritoneal barrier, but essentially it's a collagen fiber plate that separates these two. Now, tumors can infiltrate. In a very aggressive cancer, the tumors can infiltrate into this layer and be more invasive, and can reach out into these blood vessel region, and there might be growth of blood vessels into the tumor as well. So it's not like exclusively sitting on the top of the mesothelial layer, but mucinous neoplasms, which are non-cancers, are typically at that surface layer, unlike a poorly differentiated adenocarcinoma that could invade much deeper. And there are milky spots through which the cancer cells also can get into the deeper layer. Now, you're all very familiar, or maybe most of you in the group are familiar with the cytoreductive surgery that is done for these tumors. And Sugar Baker, I want to honor Dr. Sugar Baker's work, who popularized this approach in early 1990s. There are two parts to this approach. One is removing all visible tumor, which requires removal of the peritoneum that is involved with the cancer or tumor, and then also removing any organs that may be affected by the tumor. And then giving intraperitoneal chemotherapy, which is chemotherapy administered into the peritoneal cavity. And the typical one that is often used at the time of site reduction is the HIPEC. And then we also grade as to how well the cytoreduction was performed. And obviously, we are aiming for a complete cytoreduction, which is CC0, no disease. But if the residual disease is present, it can be graded based on the size of the residual disease that is left inside the abdomen. Our goal is always to achieve a complete cytoreduction. You've seen this picture probably in many forms. So this is a closed type of heated intraperitoneal chemotherapy where the catheters are placed inside the abdominal cavity, and you're using a perfusion pump to heat the fluid in which the chemo is placed, and the patient is receiving this heated intraperitoneal chemotherapy for typically 90 minutes, sometimes shorter, sometimes longer. But the idea is to be able to treat the peritoneal cavity after removing all the tumor from the abdominal cavity to further eradicate any microscopic cells that often are present in the peritoneal cavity. So that's just the setting the foundation of what I am going to talk about. Many of you are very familiar with what I have already discussed, but from this point on, most of the information that you will be hearing might be entirely new, or at least you might have heard some of it, but they're all challenges that we are trying to solve. This is where the surgeon scientist perspective comes in. Now, one of the key challenges with peritoneal disease is it is very difficult to diagnose. And then subsequently, to even follow these tumors in terms of surveillance, there are some challenges in terms of how we follow these patients. What are the best tools that can be used to identify recurrence at a early stage? And how do we improve on whatever technology or technique that we currently have available to us? And the second is it's also challenging to treat. I know some patients with mucinous neoplasm are essentially cured with a cytoreductive surgery. That's the best cohort of patients. But then there are also cohort of patients who have poorly differentiated adenocarcinomas with signet ring cells who may not enjoy the same outcome that a non-cancer appendix tumor patient enjoys. And so there's so much opportunity for us to improve the treatment options for these patients. So I'm going to talk about, there are many other challenges. So our challenges are not just limited to the two that I'm showing here. However, just for the focus of this presentation, I want to focus on these two. Difficult to diagnose. We will specifically talk about liquid biopsy and imaging, and then challenging to treat. How can we overcome this, and how can we personalize some of the treatment? Now, many of you may have heard about circulating tumor DNA. Circulating tumor DNA is essentially a DNA that is present in a tumor cell that is shed into the patient's bloodstream after the cell has died or necrosed off. So that's during the cell cycle. Typically, these cells are releasing the circulating tumor DNA. Now, ctDNA in gastrointestinal cancers started off with a study in rectal and colon cancer. There are several very important landmark clinical trials that have been done that have shown the benefit of circulating tumor DNA in managing particularly colon and rectal cancers, GI cancers to be broad, but a lot of these work has been done in colon and rectal cancer. These are all additional papers, stage 3, stage 2, and so on. But what is the challenge here? What is the challenge in circulating tumor DNA when it comes to the patients I take care of? Right? The problem is one, when you look at the circulating tumor DNA data, only 42% of patients who had any recurrence actually had circulating tumor DNA detectable. They was not detected in 100% of the patients, which means that there is a substantial number of patients in whom cancer can come back or it is back, but the circulating tumor DNA is not detecting it, right? Because of the lack of sensitivity. Now, specifically when you look at it, and this is verbatim from the paper that originally described circulating tumor DNA, is that they say, of note, circulating tumor DNA from neoplasms confined to the central nervous system, which is the brain, and those with mucinous features was infrequently detectable. This suggests that physical obstacles such as the blood-brain barrier and mucin could prevent circulating tumor DNA from entering the circulation. This is a big challenge, right? A liquid biopsy test that is routinely used in managing GI cancers is almost useless in patients with mucinous type of cancers because of the physical barrier, and the circulating tumor DNA does not enter into the circulation unlike the non-mucinous cancers. But then even so, with the blood peritoneal barrier, that is one more barrier that actually makes the circulating tumor DNA not helpful, because the tumor is present in the peritoneal cavity. And for information from the peritoneal cavity to get into the blood circulation, it has to go through many barriers. So in majority of the patients, those barriers limit what can get into the circulation. So if you are studying the circulation, existing technology doesn't help us. So we looked at it because I was studying this, and in my patient circulating tumor DNA didn't really make any difference at all. We wanted to show this to the world, and certainly we looked at our own set of patients, almost 300 some patients. We studied these patients and looked at the circulating tumor DNA, and this is one of my wonderful residents who now has chosen to become a surgical oncologist, who did this work. And we were able to show that the circulating tumor DNA is unreliable in gastrointestinal peritoneal carcinomatosis. And specifically, what we showed was when circulating tumor DNA test was done in patients with peritoneal carcinomatosis, in 50% of the patients, it was negative. And even when it was detected, it was in such low amounts, and whether it was relevant might be relevant in those patients, but however the amount of circulating tumor DNA that you see in peritoneal carcinomatosis is very low. So here what I'm showing is in patients with peritoneal carcinomatosis, the quantity of circulating tumor DNA that gets into the circulation is really low. Compared to a patient who has got a liver or lung metastasis, the amount of circulating tumor DNA that is seen in their blood is much, much higher. Right. So a big issue about how to solve this. So what we are doing is looking at something very different, and these are called exosomes. Now, exosomes are how our cells communicate with each other for even normal cellular processes. These are extraordinarily important messages that are carried through these nanovesicles. So basically, this is what it looks like. These tiny little vesicles. They are membrane bound and they are produced by cells, but they are packaged with incredible amount of information. This is how cells communicate. They send these exosomes and they go to the next cell and teaches that cell to do whatever that parent cell was trying to teach it. Right? Or a friend cell is trying to communicate. So, but essentially, this is how their cells communicate. So they are packaging. So the cells package this information. Here is how it starts. And then they push these exosomes out. And these exosomes are now present in the body fluids and in the environment, tissue environment, and they go and communicate. What we are trying to do is figure out if we can use these exosomes, because these exosomes have been implicated in cancer. They are available in body fluids. We have tested it and they are present in any body fluid: blood, saliva, peritoneal fluid, lavage, ascites, urine, and so on. And they provide very important information, and they are implicated in pretty much any part of a cancer progression or cancer formation. And that is why we are studying this. And we have done our initial study using patients with colon cancer, but applicable to appendix cancer as well. Essentially, these are patients who had either carcinomatosis or metastasis, liver or lung metastasis, or primary colon cancer without any cancer spread. We isolated these exosomes. So basically, you can take a patient's blood, put it through an isolation process, and get that exosomes pellet. So here, this is what we eventually get at. And then we take these pellets and study them through many different ways shown here: electron microscopy and gene expression and proteomics and all of this. What we were able to show is that first and foremost, tumor cells produce more exosomes because we had healthy controls who have no history of cancer. We used those healthy controls and we looked at the amount of exosomes that are present in their bloodstream, because exosomes are produced for normal processes as well. Even just how our blood cells mature and other things, exosomes are essential for normal physiologic process. The difference is, for normal physiologic process, the amount of exosomes that are present in the person's blood is much lower compared to a person who has cancer, whether it is a non-metastatic cancer or peritoneal carcinomatosis or even liver or lung metastasis. But what is very important about this study is that in every patient with peritoneal carcinomatosis or cancer spread to the abdominal cavity, we were able to identify exosomes and the similar findings in them as well. So, unlike the ctDNA, this one was present in about 100% of the patients. Then we studied it in terms of what message is carried in these exosomes. And we were able to show, and not going into the details of this 448 genes that were different, but essentially, even for someone like without any description of the genes, what you can see is this green area is person like healthy controls. These are people who do not have cancer. Whereas the people who do have cancer, they have a very different red-like patterns that each one of the red blocks represents a gene that is overexpressed compared to a healthy control. And this is important when we are thinking about a liquid biopsy. Is it whether it discerns or discriminates people who have cancer from the people who don't? And we were able to show that the exosome gene expression can absolutely 100% differentiate the people who have cancer from the people who don't. The differences in genes might also be different in the type of metastasis that the patients incur, right? And that's for future studies, but essentially we want to show that proof of concept that exosomes in blood might be a more sophisticated and more sensitive liquid biopsy for patients with peritoneal disease compared to the currently available circulating tumor DNA. And we published this data, and we have written more about this, and there is ongoing work that is happening in my lab to be able to expand this and make it a really an available diagnostic tool. We expect that this would happen very soon. And here are some of the big differences. Circulating tumor DNA requires larger blood volumes. Exosomes can be done even with 1 ml of blood. Circulating tumor DNA is unstable because our body destroys the DNA, free DNA, whereas exosomes, they are packaged in this lipid membrane. So they're essentially protected. The information inside the exosomes are protected and stable for a long periods of time. Circulating tumor DNA provides very limited information because it is studying what is happening in a dead cell, whereas exosomes are really trying to look at in real time, dynamic way, what are the living cells talking about? What are the living cells communicating? Right? So the sophistication of this information and the value of the information is very different with exosomes compared to a circulating tumor DNA. And I truly, truly believe in the next few years, exosomes will become the most important liquid biopsy that is going to be studied and brought to the diagnostic front. The next one, I want to switch gears. So difficult to diagnose, the next problem that we encounter is with imaging. Right? We talked about the blood-based biomarkers, which is one of the challenges, and we talked about as to how to overcome that blood-based biomarker challenge using novel liquid biopsy studies like exosomes. Now I want to show you what we can do with imaging. Now, the problem with CT scan, and I'm sure many of you experienced this frustration, is the lack of accuracy of CT scan in diagnosing peritoneal tumors, particularly tumors less than 1 centimeter. And image occult peritoneal carcinomatosis can be seen at laparoscopy, but the CT scan may not show it. And that happens, particularly in gastric cancer, very frequently. Now, here is a patient of mine where this is the CT image, didn't show much, but when I did the laparoscopy, I saw this. I was just quite surprising to see how much the CT scan did not show. Again, you can only use the test to what it is capable of doing. It sees the liver very nicely. You can see the liver very nicely. It sees the soft tissues, it sees the spleen and other things. But what it can discern is this flat lesions, which are very, very flat, to be able to seen as a projection on a CT scan because it's too flat to be appreciated by the CT scan. And so this is what we see when we do a laparoscopy, unfortunately, in some of our patients. Now, what is unique about peritoneal carcinomatosis? So this comes down to the biology of the cancer. And I know this figure looks complicated, but I want to simplify this. What is unique about peritoneal carcinomatosis is the amount of fibroblasts, which are kind of these type of cells that actually form the tumor structure. So there are cancer cells, but or tumor cells, but these cells are covered by these fibroblasts, which actually makes it a very thick tumor that is hard to penetrate with chemotherapy and so on. This is true even in pancreas cancer. So they are called as stromal rich tumors, and they consist of fibroblasts. These fibroblasts, they express a particular protein called as fibroblast activating protein. Now, what happens with this is that you're trying to figure out, okay, if that is what they do, can we use that biology to design an imaging study that is focused on identifying that type of a cell? Right, so that is where a different PET scan is coming out right now. It is in clinical trial, but I'm hoping that we will have that open at UCI very, very soon. It's called as FAPI PET. It is a fibroblast activating protein inhibitor PET CT scan. Right? And I'll show you some of the images. So for example, this is a patient with peritoneal metastasis who had an FDG PET. FDG PET is the regular PET scan that we use using glucose. And if a cell is not needing as much glucose, it may not be as active with an FDG PET. So here, this is what the FDG PET shows. Whereas this is what the same patient's FAPI PET shows. You can see the areas that are lighting up, these orange yellowish areas are all areas of tumor. That was not at all seen with the FDG PET, but the FAPI PET is picking up all of those areas of additional disease. Now, certainly FAPI PET has higher sensitivity in finding out areas that have stromal rich tissue and can be used for peritoneal carcinomatosis. And this is something that we would be bringing in clinical trials because it is not a current diagnostic tool that is available as standard of care. However, because of the promise of this particular technology, it will be tested in clinical trials. I'm sure many institutions will open this clinical trial, UCI being one of them. There are many companies that are thinking about it, including GE Healthcare, but hopefully this technology, if it's proven effective in identifying or proven sensitive in identifying peritoneal metastasis, I hope it will become a standard of care soon. And that's from the imaging standpoint. And then finally, I want to talk about resistance to treatment and how do we personalize treatment. Now, one of the things that happens is systemic therapy alone may not be sufficient to treat patients with peritoneal disease, and that is why we give them intraperitoneal chemotherapy. And this cartoon just depicts that there is a barrier, so the chemotherapy may not enter into the peritoneal circulation effectively. So when we give chemotherapy directly into the peritoneal cavity, that is one way to address these cancer cells. And there is a lot of ways to do that, including HIPAC, but it can be normothermic chemotherapy, it can be PIPAC, and so much more. But the concept is putting chemotherapy directly into the abdominal cavity and allowing for that chemotherapy to kill the cancer cells because the chemotherapy you administered through the IV may not get there. Okay. The problem is with this approach is that how do we know which treatment is actually the most effective treatment to give inside the abdominal cavity? We don't have good tumor models to study this because we need models to be able to test this before we start treating patients with any new drug combinations. Now, the typical tumor models that we have are organoids, spheroids, but what we are trying to develop is a true microtumor that resembles that of a patient's tumor. Right? And these type of models is what is needed for us to advance the field and start personalizing the treatment for our patients. So this is what a vascularized microtumor model developed in our lab looks like. And I am funded by the NIH to study this and develop this for patients with peritoneal disease specifically. So this is a living tumor that is essentially a microtumor that is on a small plate that you watch through a microscope. I'll not go into much of the details, but essentially it has multiple different cells. We are recreating the tumor in vitro, not just a single cell, but multiple cells, and it's a living network. So this is what it looks like. The red are cancer cells. The greens are all blood vessels that are kind of creating that microenvironment, and there are fibroblast and stromal cells in this microtumor. My collaborators, Dr. Hughes and Dr. Heichi, had previously shown that this vascularized microtumor resembles human cancer much better than any other models that are out there, including animal models. And certainly, we don't want to use animal models. No reason to do that. Lives matter. And certainly, I've been interested in developing a non-animal model that reflects peritoneal disease. And so what we have done is to develop this model, and I'm just showing you what's the difference between the currently available, the typical organoids and spheroids model, compared to the importance of developing a living model that has a dynamic flow that you can test and deliver chemotherapy dynamically rather than just spiking the media with chemotherapy. To develop a peritoneal tumor, we really did need to create that peritoneal cavity. So essentially, this is what it looks like. If you can imagine the picture I showed you in terms of the peritoneal anatomy, this is the peritoneal cavity. The peritoneal cavity is the blue area, which is lined by the peritoneal cells, and the stroma or the vessels are separated from that peritoneal cavity by an interface, and here is where the vessels live. And what we have seen is that we are able to create peritoneal tumors. So here, these green ones are the peritoneal tumors. And we see when there is cancerous cells, there is also ingrowth of the blood vessels. So here I'm showing the ingrowth of blood vessels, and we are giving treatment to these tumors. These are patient tumors, and we have developed these tumors. So a bigger picture of the same thing. The blue is the peritoneal cavity. The green area is actually the submesothelial stroma through which the blood vessels are present. Here, the red is a patient's tumor cells, and we can give treatment directly into this peritoneal cavity or give treatment into the blood vessels and see how best the treatment responds. Here are some examples of many patients' tumors that we have created and have been able to treat. Overall, for the past several, actually couple of years, we have been developing this. And here is a microscopy image of how the blood vessel starts growing into this tumor when the cancer is kind of has an aggressive biology. We have been able to demonstrate that when we give treatment into the peritoneal cavity, this red line indicates that the cancer cells are dying, compared to a control group which did not get treatment and the cancer cells are growing. And by this, we can start testing different drug combinations. So even before putting it into the patient, if we can take the patient's tumor, grow it in this vascularized microtumor model, and test it with many different drug and drug combinations, and start using the one that is the most effective for that patient instead of just using the same drug, either mitomycin or a cisplatin or whatever drug that is being used for that particular cancer, and then finding out 3 months later whether it worked or not. I think that time is of essence when we are managing these patients, and using the best effective treatment from the get-go is crucial. And that is why these type of models are going to help us come up with the best treatment from the very first instance rather than finding it out through failures, right? So that's another way to solve a problem. It's challenging to treat, it's resistant to treatment, but let's find out what treatment might then work for these cancers before starting to treat patients with this. So in terms of challenges and possible solutions, I have highlighted difficult to diagnose. There are options with imaging. I focused on the FAPI PET-CT scan, which is a fibroblast activating protein inhibitor PET-CT, and also developing liquid biopsy, which is based on exosomes. And then in personalizing the treatment using in vitro tumor models that replicate the patient's tumor and the tumor biology to be able to select the best treatments before embarking on treating the patient with intraperitoneal therapy. So these are still science that is evolving, and I'm hoping that in the next few years, we will make substantial progress in how we take care of patients with peritoneal disease, particularly appendix tumors. And so this is to summarize what we have discussed here. All of this should connect with the patient. So at the end of the day, each one of these challenges creates enormous anxiety to a patient. And what we are hoping is while we are also thinking about the large outcome, it's also important to create that sense of confidence and a sense of security for patients is because they are having the best technology being used to manage them, surveil them, and treat them. All of this work actually comes down to just that simple need. It's not just about outcome, but also the peace of mind that we have to give our patients and not just talk about all the things that we cannot do, but talk about the things that we can do and what we have been trying to improve. Well, and I want to thank particularly the patients and families and my incredible team, because without patients and their generous participation in research, none of this would be possible. And without having brilliant people help me to be able to do this, none of this would be possible. So, once again, thank you. And I'll be happy to take all of your questions. And Adele would moderate this session, I believe. But I look forward to discussing your questions. Thank you.
Thank you, Dr. Centil. Uh, Back on here. This was just amazing. And I have to say the research that you are doing just gives us great hope for continued improvement and outcomes for our patient community. So thank you for everything that you're doing. We did receive a number of advanced questions, and so I'll go through those. And then to everyone in the audience, if there are additional questions, please put them in the chat, and we will get to as many as we can. Uh, so, any new research specific to goblet cell adenocarcinoma and any research, recent research studies, including new treatment protocols, which I think you've touched on some of that, but I'll let you expand on that question.
Yeah, so goblet cell, it again comes down to the nature of the cancer and what it means to finally the outcomes of the patients. So when we're thinking about it, right now, majority of patients with goblet cell peritoneal carcinomatosis will end up getting some form of chemotherapy treatment, and then possibly, some patients will be able to undergo cytoreduction. Not all patients are candidates for cytoreductions, unfortunately, if they have extensive disease. But if they did not have extensive disease, they are able to undergo cytoreductive surgery. The issues are once we have done that, how do we monitor these patients? How can we identify early recurrences? How can we further improve the treatment that was given to the patient? Did we give the most effective treatment? And then what do we do about patients who are not candidates for cytoreduction? That's a large cohort of patients as well. So I do think that some of the research that we are doing actually pertains to that. Is how do we monitor these patients? Is the FAPI PET a better test to be able to be used for patients who are under surveillance? Would that detect recurrence faster? And then with the liquid biopsies, because some of the tumor markers that we have right now are not very sensitive. So figuring out what liquid biopsy test would be the best suited for managing these patients. And then finally, thinking about intraperitoneal chemotherapy, I know there are several trials that are looking at unresectable peritoneal carcinomatosis, goblet being one of the histologies that often cause that problem. Is what type of intraperitoneal chemotherapy can be administered to keep the disease under control? And I think that there's HIPEC trials and PIPAC trials, but then there's also normothermic intraperitoneal chemotherapy trials, and we are going to launch one very soon at UCA as well, is because of the feasibility, the safety, as well as convenience for patients to be able to undergo repeated intraperitoneal therapy. And I think that's also important is because if the patients are on treatment, keeping in mind that they have to be on it for a long time.
Okay, thank you. The next question are IPMNs often found in patients who present with appendix cancer? And I think they're referring to what you would know better than me, pancreatic.
Yes. So intraductal papillary mucinous neoplasms is the type of mucinous tumors that can happen in pancreas. Is it seen more frequently? I'm not sure that we have a solid answer to that question as to whether mucinous tumors of the appendix are linked to mucinous tumors of the pancreas. I don't think we have a linkage between the two at this point, to the best of my knowledge.
Okay. How does a patient receive compassionate care from a pharmaceutical company?
Yeah, that's a challenging pathway, but it requires a physician who strongly believes that there is an indication for a drug that has not been used for this indication or has not been FDA approved for this indication, but yet believes that it should be used. And that is how a compassionate use of a drug that has not been approved for an indication can happen. Really is a regulatory issue also and a safety issue. So it is an interaction between a treating physician and a pharmaceutical company and making sure at the institution level there is a regulatory clearance to use that drug because that's also a regulatory compliance part that you have to satisfy when it comes to your institutional authorization or approval to use the drug for non indicated conditions. But can be done. It just depends upon how easy it is to work with the pharmaceutical company and how rigorous the institutional regulatory bodies are.
Okay. Do bowel obstructions caused by adhesions or scar tissue from multiple surgeries happen as much or more than bowel obstructions from this cancer? So,
The bowel obstruction from adhesions?
yeah, so when you have the surgery, are the adhesions and the scar tissue causing more bowel obstructions than the tumors themselves?
Yeah. Uh, um, Actually, the likelihood of bowel obstruction after any surgery, regardless of the type of surgery, is there. It can happen in about 10 to 15% of patients. But I would say that the bowel obstruction caused as a result of surgery is less frequent as well as can be managed more effectively than the bowel obstruction caused by the cancer. Right? The bowel obstruction caused by cancer is irreversible. All that you can do is palliate those patients by putting a venting gastrostomy tube or maybe doing a palliative resection or an ostomy type of procedure to alleviate that bowel obstruction. But oftentimes that's actually a terminal event in patients with carcinomatosis, unfortunately. So to me, if the question is focusing on what is the trade-off, I would any day take a bowel obstruction due to adhesions over a bowel obstruction due to cancer.
Okay, thank you for that clarification. Uh, What do you recommend for abdominal pain years past CRS and HIPEC? Um, and this patient no longer sees a surgeon who specializes in CRS HIPEC.
Yeah, chronic pain can happen in patients when they undergo extensive surgery, and it could be due to multitude of factors. Some of it could be musculoskeletal imbalances, a type of issues with their incisions, and so on, or just very non-specific. Some of it could be due to bowel or GI disturbances that is just kind of ongoing that results in periodic kind of this crescendo decrescendo type of pain is because based on what they ate or how they feel there might be some abdominal pain that can happen. So discerning what is the cause of pain, are we dealing with a musculoskeletal type of pain or is it more of a GI disturbance that's causing the pain is important. When I encounter patients who have chronic pain after surgery, these are all the things that we are trying to figure out. Are we treating a musculoskeletal pain or a GI pain? If they have GI disturbances that are causing pain, occasional cramping or serious cramping or diarrhea that is causing them discomfort, I refer them to a motility specialist and usually a GI physician who specializes particularly in post-surgical GI disturbances. And they often are able to work with the patients, understand what is the root cause of the problem, including dietary changes that may be needed to alleviate some of the truly GI related abdominal pain. So, a proper evaluation and clearly understanding the source of pain would help the next steps in managing those kind of chronic pain.
Thank you. Um, let's see. Is there a way to extract thick ascites via laparoscopy?
Yeah, I showed that picture just because I've had these questions asked.
Mhm.
As you can see, when you have patients with diffuse mucinous tumor in the abdomen, it sometimes is so hard to pull that out through laparoscopy because if you look at the laparoscopic instruments, they are metal instruments with holes in them. Like, how do you scoop out that gelatinous material entirely, like with complete confidence that we have gotten everything out just with laparoscopy? I find that very challenging. to do that because it just falls out, right? It just literally slips out of your grasper that you're trying to use to grasp it. So it is more of how do I say, what is the objective of the operation? When patients ask me, say, why not? Why wouldn't you do that? Is to me, you're one very good chance at getting control of this disease. And patients heal incisions well. It's not the incision that's the problem. It is about the chance of this tumor coming back. So my focus is always to make sure that we are doing a complete cytoreduction and minimizing the risk of that tumor coming back. And if that can be accomplished only through an open operation, then I offer the open operation to those patients. Right. So I rarely ever do laparoscopic cytoreductions in my practice because of the nature of practice that I have. I see only fairly advanced patients. But then it is also making sure that they're getting that operation that is going to result in the durable outcome that they're hoping for. Because it's no fun going back to the operating room a year and a half later when you had one. That's not what the patients are looking for.
Right. And I think you touched on this next question, which is simply how to stop tumor growth.
Yeah, these tumors grow. Their physiological processes are very different. So they will get energy either from the peritoneal milieu itself. There is both energy as well as information that is coming into the peritoneal cavity that is triggering these tumors to grow. And then there are also tumors that are growing into the bloodstream or into the deeper part, and they can derive blood from the circulation also. There are many ways that these tumors grow, but the growth factors are happening both inside the peritoneal cavity and from the systemic circulation.
Okay. Under what conditions are retroperitoneal nodes qualifying HIPEC as an option for patients?
Yeah, right. So I think this is an important question. What you're touching on is what happens in patients with extraperitoneal metastasis collectively. Right? And I will answer it in the general terms is that it's patient selection, patient selection, patient selection. You have to figure out in which patients it makes sense to offer cytoreductive surgery. Because ultimately, the goal of the operation is to improve survival. That's what we are trying to discern, and keeping in mind the risk benefit ratio and the effect on the patient's quality of life. Right? These two also have to be factored in. So you're trying to figure out, will this operation improve survival in the context of cancer having spread outside of the peritoneal cavity? If the cancer has spread outside of the peritoneal cavity, how am I going to improve outcomes by removing the cancer in the peritoneal cavity? What has been done to the cancer outside of the peritoneal cavity? Is that cancer completely taken care of, treated, and will that become a point of progression down the road? So that is what we are trying to discern, whether it is an extraperitoneal retroperitoneal lymphadenopathy or a liver met. Again, comes down to the same thing. What have we done for the extraperitoneal metastasis? How do we improve the outcomes by offering cytoreduction? And does it make sense in the big picture?
Thank you. Is fasting helpful to kill cancer cells?
Yeah, I get asked this question a lot by my patients. I think we can talk about nutrition and cancer by itself like for a whole day, and we'll still go away with different thoughts and opinions about nutrition and its influence on cancer. But what we can all agree is just the fundamentals. Cancer finds its nutrition whether you provide it or not.
Mm.
That's why it does what it does. Why do patients with cancer lose weight? Why do they lose muscle? Because it is extracting what it needs from the patient's body, from its own host. That is why it is considered malignant, right? So this is a malignant behavior. And the malignant behavior is eat something that is actually providing its home, right? And so whether a patient fasts or not, the cancers will find the nutrition it needs to grow. What is important when we think about nutrition is how do we optimize nutrition to improve outcomes, right? And the general concepts actually are true. Is one is avoiding processed food. trying to eat a lot more of vegetarian based protein, increasing the fiber. Not all patients can increase fiber, so take this with a grain of salt. But as human beings who are trying to maintain good health, nutrition matters to us, and what we put in matters. And generally, thinking about clean, healthy food that has lots of vegetables and fiber is essential. You may have to change it based on the type of GI procedure that has been done in an individual patient. But however, the concepts are still cancer is going to find its nutrition. How do we support our nutrition or the patient's nutrition while they are dealing with cancer? So it comes with healthy nutrition, focusing on the amount of protein, and still making sure they are maintaining a good level of exercise that maintains their muscle mass.
Thank you. Any updates on, and I may be saying this incorrectly, on palbociclib treatment?
Yeah. So I think you're referring to the clinical trial that was done at UC San Diego for patients with PMP. The initial results were presented for a small number of patients, I think 12 patients in Annals of Surgical Oncology. I think the paper got published there. Not, I have not heard any further updates about palbociclib at this point for the management of patients with unresectable appendiceal mucinous tumors. Yeah. It's a signal. We'll have to see how it pans out.
What is the best treatment for low grade? Although I think you touched on this in your presentation.
Yeah. Surgery still is the cornerstone for management of patients with low-grade appendiceal mucinous neoplasm for two reasons. One is these neoplasms are not responsive to chemotherapy, right? You see that gelatinous mucinous material, there's nothing that chemotherapy is going to do to that
Mm.
mucin, right? And it's probably not even getting there, right? But however, surgically, we can completely remove these tumors. And it has been shown over and over again that these are the patients who are long-term survivors, and complete cytoreduction will result in that survival benefit, and sometimes in some patients cure.
Thank you. What are symptoms of recurrence of PMP and what is
Yeah,
some recurrence data?
I know. It's the symptoms are quite challenging, right? Is the and the reason why I say that is because the patients have some elements of symptoms that may have as a residual effect from a major cytoreductive surgery. In some patients, they may have no symptoms at all. It is just during follow-up we are starting to see maybe an imaging abnormality that doesn't look right, and we are concerned about it, and so on. So there are ideally, if you're under care of a team, you shouldn't have symptoms to find recurrences. There has to be an close surveillance program that has been put forth for the physicians to identify any abnormalities at a much early stage before it causes symptoms, whether it is an imaging abnormality or a blood-based biomarker abnormality, that it is being followed much closely than symptoms resulting in detection.
Thank you. Okay, this is a specific question that is interested in the recommended treatment for T4A and 0M0 mucinous appendiceal adenocarcinoma when mucin was observed leaking from the tumor during a colectomy, but no evidence of PMP.
Yeah. So the again, not knowing the nuance of this case or the type of cell that was involved in a mucinous adenocarcinomas could be anywhere from well to poorly differentiated with signaturing. So there are many things. I know it's node negative, but it is still a T4A. With regards to the spillage, I think the question refers to what happens if there is an intraoperative spillage of cancer when an appendix tumor is being removed. There are two groups of thoughts, and I don't think there is any right or wrong answer. Is if there is no peritoneal involvement, does the perforation itself warrant treating the patient with heated intraperitoneal chemotherapy? Right. That's probably what is being asked. I think you will have physicians in this country who would offer it versus physicians who may not offer it. But I think it just comes down to the patient's comfort and the current existing data that we have for T4 cancers. Now, many people will quote the HIPEC T4 study that was done in Spain for patients with T4 colon cancer, in which group of patients mitomycin hypac was used. And there is some data, but you can look at the holes in this data as well. So there are believers and non-believers. It all depends upon the patient's preference.
Okay, thank you. I think you covered this next question in your presentation, but any new diagnostic tools for PMP or anything over and above what you covered in your
I
presentation?
think these are some of the fronts that things are moving, right? Really, what we are thinking about, what is the liquid-based way to identify these tumors, and what are the imaging-based ways to identify these tumors? And what I mentioned are the two promising areas of
Mhm.
advancement that are currently happening.
Thank you. Thoughts on prognosis related to non-mucinous infiltrating adenocarcinoma, grade 2, appendix perforated, but no metastases seen on a CT?
Yeah, it depends upon the type of treatment that was done and as to whether the patient received systemic therapy, if and so on. And it also depends upon it's moderately differentiated, right? That's what was mentioned. It's grade
Hmm.
2. Yeah. So if it's grade 2, the likelihood of recurrence is lower than a patient with a grade 3 cancer, poorly differentiated, or who have grade 3 with signet ring. So those patients tend to have a higher rate of recurrence compared to a well or moderately differentiated appendix adenocarcinoma without any evidence of peritoneal metastasis. Usually these patients tend to have excellent outcomes and have excellent disease control for long periods of time.
Thank you. If you are deemed inoperable, does that mean no chance for remission?
Yeah, I mean, with peritoneal dissemination, if the patient is not considered a candidate for cytoreduction, what is the likelihood of control of disease, right? Again, for appendiceal mucinous neoplasm, it is different from that of a patient with peritoneal carcinomatosis. But be as it may, remission is not a word we use. So, remission is someone who has complete control of cancer, has no imaging evidence of cancer, and can probably come off treatment at this time. That is not something that is possible in the absence of cytoreductive surgery.
Okay.
But patients can have durable disease control, like stability of disease. That's not remission. Stability of disease with particularly mucinous neoplasms. They might have a disease that just looks about the same for years together, like even 3 years, 4 years. It just looks about the same amount of tumor, and patients are functioning reasonably well, even though they have imaging evidence of tumor. That's more common with the mucinous tumors, where mucinous neoplasms compared to adenocarcinomas. Adenocarcinomas tend to progress.
Okay. If CRS has been determined to not be an option, what should expectations be regarding seeking a second opinion?
Oh, second opinion always, always. Even third opinion always, always. No
Okay.
questions about that.
Okay. And then with regard to the clinical trials, some, domestic versus international or all over, and you touched on some of this in your presentation, which of these trials do you think show the most promise?
Hmm. So, to the best of my knowledge, specifically for appendix cancers, we don't have a trial that is exclusively dedicated to appendix cancers. But there is a lot of work that is being done in other cancers with peritoneal carcinomatosis or cancer spread to the abdominal cavity. Um, and there are some in Europe that are currently ongoing. And I can refer to my own clinical trial that we are doing here in the US, which is for patients with gastric but peritoneal carcinomatosis. Now, what do we gain by doing these trials, right? Is because the knowledge is translatable to other diseases. If a particular treatment approach, say for example in gastric cancer, is effective, then it is easy to extrapolate that information to similar aggressive types of cancers that have spread to the abdominal cavity. Now, gastric cancer has a very aggressive histology. Poorly differentiated signet ring is what the typical histology of gastric cancer is. So if a particular therapy is effective, then you can use it or at least think about using it for other cancers. So there are some promises, and I certainly think that the EA 2234 or STOP-GAP2 trial in the US will provide a lot of information about managing patients with peritoneal carcinomatosis, including some of these liquid biopsy approaches and advancing the liquid biopsy approaches.
Thank you. On the fibroid PET CTs that you discussed in your presentation, are those readily available?
It's not readily available yet because the efficacy or sensitivity and specificity of these imaging studies have not yet been proven, particularly for peritoneal carcinomatosis. So they are still investigational, and they are going to be offered to patients through clinical trials. So we are hoping to get that up and running so that we can start using that and provide better answers. Because at the end of the day, only when we can prove it is effective will then the insurance companies will actually pay for it. And so there is also a need to show the effectiveness of these imaging studies. So right now it is done as an investigational imaging, and so it's not readily available, unfortunately.
Okay. But hopefully we'll get
Soon,
there.
hopefully
Yes, soon.
soon. Yeah, there are a lot of companies that
Mhm.
are interested in it. It is just that you need to do a trial, train radiologists to read it, because it's also important for radiologists to know how to read these scans. Just like how we started having FDG PET, radiologists have to train to read them, and then you have a specialist like the nuclear medicine specialist who are trained to read that FDG PET. Similar to that, we have to train our nuclear medicine radiologists to read FAPI PET and understand where it is seeing cancer versus some of the non-specific findings that often happen. That's why we need a trial to teach all of us as to how to use this kind of technology.
Have you ever treated a patient with polycystic kidney and polycystic liver disease? Do cysts show up differently to PMP in a PET scan or not? Interested to know if they appear the same.
Yeah. So the cystic kidney disease, polycystic kidney and polycystic liver disease, they are not PET active because they are just cysts. So they never are PET active. The question is, would that look different from a mucinous disease? Of course it does, is because mucinous disease is not very confined like a cyst, which has a clear wall. It almost looks like pebbles scattered inside the viscera. So when you look at it, it looks like the kidney has the cyst and they are inside the kidney, whereas mucin is usually found outside an organ and doesn't have the same clear defined boundaries like a cyst would do. So you can easily discern the difference between a mucinous dissemination from a cystic disease.
Okay. Could you comment on the latest thinking on the MRI use with and without gadolinium?
Mhm. Yeah. MRI, particularly with gadolinium enhanced MRI, there is a specific protocol called the peritoneal protocol. And it is done in some institutions. You just, again, like anything else, the radiologists and the technicians have to be very familiar with what that peritoneal protocol looks like, but certainly has higher sensitivity than the regular CT scan in identifying peritoneal disease. But the practical problems with that is one, many patients are not able or willing to undergo MRIs regularly every 3 or 6 months because of the physical disturbances associated with it, because you're in a flat table for 45 minutes and their back hurts, their belly hurts, and some patients are claustrophobic as well. So there are, from a sensitivity standpoint, MRI gadolinium peritoneal protocol has higher sensitivity than the CT scan, but not all patients can undergo that routinely.
Thank you. How quickly do non-mucinous tumors grow?
It varies. It varies. Again, it depends upon so many other features that we talked about, right?
Mhm.
What is the grade of this cancer? Is it a well differentiated, moderately differentiated, or poorly differentiated? And does it have signet ring? And if it has signet ring, what is the percentage of signet ring cells present? Like those cancers, if they have more than 50% of signet ring, it can grow very rapidly. Compared to a well differentiated adenocarcinoma, it would grow much slowly.
Okay. So in this specific situation, it's G2 with no signet ring.
Yeah, it's so how quickly, that's a hard question to
Mhm.
answer,
Mhm.
right? Is because we don't know what the doubling time of that tumor is in an individual patient and what is the burden of tumor that is present in that individual patient. So that's why we monitor these patients closely because we don't know what the doubling time is and how quickly it will grow. And that's why the close imaging surveillance happens. You can image a patient as close to 3 to 4 months, and if you're comfortable doing it every 6 months, so it varies.
Mhm. Okay. We touched a little bit on the palbociclib. In this situation, if it's low grade, well differentiated mucinous adenocarcinoma, but the CTs show minimal or no change, what would be the impetus to begin treatment if recommended?
So just to restate the question so that I want to make sure I'm grasping this
Mhm.
question. So in a patient with well-differentiated mucinous adenocarcinoma of the appendix, who now has evidence of recurrence at
Mhm.
this time with minimal amount of disease, is this a patient who should entertain palbociclib treatment? Okay.
Yes.
That is a question for the investigator who is willing to offer palbociclib because it is still not standard of care. So it has to be administered either through a trial or an exceptional use. And based on what I know about that clinical trial, the palbociclib, it was primarily for mucinous tumors that are unresectable. So
Mhm.
that is what they used it for, not for patients who could potentially be candidates for redo cytoreduction. So I think there is a lot of things that needs to be clarified in terms of what is the indication for palbociclib. And this is where really working with the individual physician who knows a lot about the patient's disease and who is offering the treatment would be helpful.
Thank you. With regard to CTs for a PMP patient, is a scan with dye superior to a scan without dye?
Typically, a scan with dye is what we are ordering and what we are looking for. But in some patients, if they have kidney dysfunction, you can use it without dye, is because the mucinous tumors will show up. But the problem is when there is no highlighting of organs, sometimes it's hard to know where the organ ends or what are you actually looking at. So the
Mhm.
preferred scan, even for mucinous tumors surveillance, is a CT scan with contrast if the patient's physiological condition is permissible to getting that IV contrast.
Okay, thank you. Another question that came up related to the Icarus study that was done at Sloan Kettering on HIPEC or EPIC, and we understand, that study is completed. It took place over 3 years, and so for that particular facility, they have stopped offering HIPEC, and so for our patient community. Could you just make some comments on whether or not patients should continue to pursue HIPEC since other facilities still offer that?
Yeah, I think this has become a point of diversion, like diverging opinions at this point, and I would say so. Basically, what do we know thus far? What do we know is for patients who had colorectal peritoneal carcinomatosis, colon peritoneal carcinomatosis, the Prodige 7 trial, which is a randomized control trial from Europe, showed that addition of 30 minutes of HIPEC that used oxaliplatin did not make a difference. Right? So that is what we have, right? The Eucharist study, I understand. So the Eucharist study is something that was done using EPIC based treatment. So that is yearly postoperative intraperitoneal chemotherapy treatment in patients who have colon or appendix carcinomatosis that have undergone cytoreduction. And this is a single institution study done by a single surgeon with, or maybe a couple of surgeons. But however, the FUDR type of treatment that was offered, which is not readily available and is quite expensive, we have to really think about, is that sufficient for us to completely take away HIPEC as an option? Is that sufficient data? Is where the dilemma about whether we should offer or not. Is there a PCI cutoff for which we should offer? Lower PCI, no HIPEC, higher PCI, HIPEC. There is just a lot of noise in the field at this point, a lot of confusion in the field at this time about what is efficacious and what is not. And since it's very challenging to study appendix cancer, oftentimes many of what we do is an extrapolation of what happens in colon cancer, because colon cancer is much more easier to study. So there are few clinical trials that are currently happening in Europe, especially when colon cancer. GCOP is a study, GECOP is a European study that is actually looking at mitomycin HIPEC, which is what is often used for appendix cancers as well when they undergo cytoreduction. So they are looking at patients who have undergoing cytoreduction and they are giving them mitomycin HIPEC versus not. And they are going to look at the peritoneal recurrence in these patients. I'm hoping that with more and more studies testing different drugs, we will be able to get to a more objective answers and not just your own subjective feeling of whether you want to do HIPEC or not or what the patients want. Because now the field is a little bit not there yet to make ultimate recommendations. I do think that the physicians are making recommendations based on the patient's interest and whether they are so keen on having it done is because mitomycin hypec can be done safely. At least in my hands, I've done almost close to 1,000 of these operations, and rarely do I see a major issue with mitomycin hypec. So the question that we ask is that even if it is a 2%, 3% benefit, is it reasonable to add that to the cytoreduction? And I have an honest discussion with the patient, and I'm okay with either ways. But however, I just present them the data, present them the safety data, and present them the data just like what we know and what we don't know. And I have an informed decision making with the patient.
Thank you for that perspective. Can you explain PCI in simple terms?
Yes. So peritoneal cancer index, right? So peritoneal cancer index essentially gives a description of the amount of tumor that is present in a patient's peritoneal cavity. And because just the process of cancer spread to the peritoneal cavity is peritoneal carcinomatosis. That's just the process that's present. But the outcomes of the patients are influenced by how much disease is present in the peritoneal cavity. So patients with very little amount of tumor in the abdominal cavity are more than likely are going to have better outcomes than a patient who has a very large amounts of tumor present in the abdominal cavity. So for us to have a proper communication, a common terminology of description of the burden of disease is why the peritoneal cancer index has been developed. It looks at various regions of the abdomen, essentially 13 regions. And we are really looking at how much tumor or is there tumor, and if tumor is present, how big of a tumor burden is that in that region. So collectively, when we put it all together, we are able to then give a description of the amount of peritoneal tumor burden that's present in a patient, right? Very simple. You're looking at the different regions and saying, is a tumor present? Yes or no? If it is present, how big of a tumor burden is it? And this gives us a common terminology to communicate as surgeons. And when we talk about research, it also provides us a common terminology to use. So generally, if a patient has a tumor burden less than 10, it's a low burden. 10 to 20 is probably moderate burden. Anything more than 20 is high burden, with a range going from 0 to 39. Right? So 0 is no tumor versus 39 is when every area has very large burden of tumor. So patients are falling into a broad range between the 0 to 39.
Thank you. Then a clarification on the exosome liquid biopsy, and the question is that referring to the tumor markers, the CA 125, 199, and CEA, uh, tests? Or so can you explain the difference?
Yeah. So basically, when we are thinking about tumor markers and CEA, CA99, they're all same concept, right? It is a biochemical material that is released preferentially by cancer cells. And can we identify that in a patient's bloodstream? And can that be used to detect cancer coming back, or even response to treatment? Can we see it dropping when we give a type of treatment? That's the idea, right? The more advanced one is the circulating tumor DNA. Same concept. It is now produced or released by the cancer cell and it is getting into the circulation. So same thing. Circulating tumor DNA is the higher level for a CEA, CA99 and other things, where it is detecting it at a much lower level, the molecular level, right? Think of exosomes as the next generation of that liquid biopsy. So we started off with the CEA level. Now we are using circulating tumor DNA, including methylation markers and so on. And exosomes is going to be the next generation of liquid biopsy, where you're really looking into the inside information and the quantity. So there's so many features that we are looking into to say the predictive capability of such a liquid biopsy. It's still experimental. It's still very much on the lab side. It has not made its way into the clinical side. Maybe in prostate cancer it has, but not for GI cancers yet. But that's how I would think about exosomes. It's the it's a next generation liquid biopsy.
Thank you. And I think the part two of this question is mostly referring to the CA 125.19.9 and CEA, but how reliable are those as indicators of the disease?
It depends, just like anything else. Is it elevated when the disease is present? That's actually the first question, no matter what the marker is, including circulating tumor DNA. If a patient has tumor cancer at that time, what do the markers show? If the marker is not elevated, then it's not useful. If the marker is elevated, then it is a useful marker to follow. So every patient is different. There are producers and non-producers also, meaning that some of the tumors will produce these markers and the markers may get into the patient's bloodstream. Some of the tumors will not produce these markers. So that is why we kind of run a set of tests at the time of the initial diagnosis to figure out what may be the best markers to use in any given patient, including circulating tumor DNA for that matter. So, because in 50% of the patients, maybe the circulating tumor DNA gets into the circulation, and in those patients, using ctDNA to monitor their treatment or recurrence might be helpful, but there are 50% of patients in whom nothing actually shows up in their blood. So, you're kind of nothing really to follow.
Okay. Okay, our last question. So, as a surgeon scientist, what are the one or two things you want us as a patient community to know and remember from your talk? Mm, mm,
That's a great question. One thing to remember, I'll say a few things, right? It's super important. I want you all to know that each one of you give us tremendous amount of energy um, to pursue science to make things better for you. For me, the way I think about my work is when I sit there in front of a patient and when I'm trying to explain to them something and that doesn't make sense, or I'm creating uncertainty and not clarity, I am not okay with it. I am totally not okay with it. When I see my wonderful patient who I have done the surgery that I thought was the right thing to do has an yearly recurrence, that really is a very painful experience. So that pain is not forgotten, it is channeled through research. And that is how I can make sense of my work, is by taking all the learnings and all the pains of my patients and channeling into doing research. It takes enormous time and energy on a different level, but however, that's the only way I know how to practice. And there are many surgeons like me who are trying to dedicate their time to advancing science for the right reasons. And it is important for you to know that all of what you're going through is not without that deeper concern for helping somebody else through learning from your experiences as well. And many of you contribute generously in many ways to advancing science. So we are working on it. That your pain is never not noticed. It is always noticed and it is channeled. The second is, as a community, we have to support research. Right? There is a lot of limited funding for research at this point, and we need to make sure that our representatives both in Congress and Senate and higher levels are really continuing to support research is because without funding we can't do it. I might have the best brilliant questions to ask, but if I don't have funding, I can't study it and I can't do anything about advancing that science. So it's also important to take that point home. Yes, all of us matter in advancing science one way or the other. By doing it or supporting it or contributing to it, it matters, and that's how we are going to make a difference in the long term. And PMP Pals and PCPMP, there are so many foundations that are generously supported by our patients, you all, is how we are able to create many of the preliminary work. It's so surprising, except for the one work I showed you. None of this has been supported through government funding. Every one of that has been supported through a patient foundation funding.
Mm.
Patients have supported that research, and I'm incredibly grateful for all the support we receive from patients. So as a surgeon scientist, I want you to remember we care about you not just while we are seeing you in clinic, every single minute thereafter. We care about how we can improve your outcomes, and we also are extraordinarily grateful for the support you provide, both as patients participating in research, but then also through your advocacy and generous support through many of these foundations.
Oh, thank you so much. Your presentation gives us great hope, and it just reinforces how much you and the medical community does care about us, and it continued advances continues to give us great hope. And you were so generous with your time this morning and all of the questions that we asked you. So we greatly, greatly appreciate it. And to those of you that joined us, thank you so much. We do hope you'll keep coming back and continuing to connect with us.
Thank
So
you.
yes, and so we will. This presentation was recorded, and we will post it as soon as we can, and so you can listen to it. And one thing I didn't mention early on that I typically mention are some of our disclaimers, and so this is educational, and everybody has their own individual situation, and you need to consult with your own care teams. But again, our heartfelt thanks, Dr. Senthil. We appreciate you, and again, certainly demonstrated how deserving you were to receive the Gabriella Graham Patient Advocate Award.
Thank you.
And to all of you here today, our heartfelt thanks, and we hope to see everyone soon.
This was amazing. Thank you again. Really
Thank
enjoyed having
you.
this conversation. Bye.
Bye, everyone.